So let's start with the, quick, brisk talks from the different authors of the research papers selected for AIIMA 2024. As a part of the session one, we have 5 papers selected. The first one will be from Snehalatha Umapati from SRM Institute of Technology from India. The speaker is going to talk about CNN transformer for the automated detection of rheumatoid arthritis in hand. So we're going to start with hand, then foot and thyroid. And so this session is mostly going to be non-breast. So welcome, Snehalatha. If you can share your slides and start presenting. Snehalatha, are you there?
So the topic, good evening, everyone. So the topic of today's session is CNN transformer for the automated detection of rheumatoid arthritis in hand thermal images. So these are the contents of the session. So coming to the introduction of rheumatoid arthritis, it is a systemic autoimmune disease. Autoimmune means our immune system itself affecting our body. So it affects the small and large joints and which leads to loss of functional ability. Rheumatoid arthritis can occur at any age, although it is most frequent in individuals over the age of 50. And women are more prone to RA, and according to the women are 3 times more likely to be affected than males. So the various diagnostic modalities include radiography, computer tomography, magnetic resonance imaging, and ultrasonography. And as we know that radiography is a widely accepted imaging modality for evaluating RA. So coming to the figure here in the left-hand side, it's a joint of a normal person, and in the right-hand side, it's a joint of a arthritic person. So in this, you can see the bone erosion and the joint space narrowing and swelling. So these bone space, bone erosion and the joint space narrowing will be very minute at the early stage. So with radiography, we cannot evaluate rheumatoid arthritis at the earliest stage. So in this, that is why in this study, we have used thermal image as a supporting modality to evaluate rheumatoid arthritis. So coming to the RA measurement technique. So we are, first of all, we are having the blood tests such as erythrocyte sedimentation rate, C-reactive protein, rheumatoid factor, and anticyclic citrullinated peptide antibodies. So as we know that if we are having fever also, the ESR level will be elevated. And if we are having some infections also, the CRP level will be elevated. So with this, we cannot confirm RA. So as I said earlier, in radiograph, the early stages cannot be evaluated using radiographs. So in ultrasound, we know that it is a user-dependent modality. In case of MRI, it is a time-consuming and expensive procedure, and it cannot be used in patients with implants. Coming to CT, CT gives only the severe bone erosion case and cannot evaluate the premature changes. In case of thermal imaging, it is a non-contact, non-invasive, passive, and radiation-free modality, and it provides a high temperature profile of the regions caused due to RA. So coming to thermal imaging, as I said earlier, it's a non-invasive and non-ionizing and cost-effective modality, and it predicts or detects the earlier stage of RA. So here in this figure, it shows in the figure A, it shows a hand of a normal person, and here figure B shows the hand of a rheumatoid or affected person. So in that, you can see the temperature differences more in case of a patient. So coming to the methodology here in this study, we have collected the images acquired the real-time images from the Department of Rheumatology, SRM Hospital and Research Center in accordance with the Indian Rheumatology Association. So here we have selected 50 normal persons and 50 RA patients. The patients who were confirmed with systemic tissue disorder, multiple joint inflammation and discomfort were selected for this study. However, those who have recently done physiotherapy, fever treatment, or phototherapy were not allowed to participate in the study. For this study, we have used a FLIR A305 SC thermal camera to acquire the real-time images. And we have obtained images of hands in 3 views, that is dorsal, ventral, anterior, posterior. Likewise, we have obtained 600 images from both 50 normal and 50 RA patients. So this figure shows the flowchart of the proposed model. So in this study, we have used CNN VIT transformer, which is a vision transformer. So here in the input, we'll be giving the normal and RA images, and it is passed through a VIT framework, and from that, automated feature extraction and classification was performed. So in case of CNN, as we know that it is a popular framework for image analysis, and it has gained popularity among various diseases. So in this research, we have used the latest development of a CNN, which is a CNN vision transformer, which uses encoder-decoder architecture for the classification of normal and RA patients. So here, this figure represents the architecture of the VIT. So in the input to image, we have given the thermal image. And from the thermal images, patches were extracted and the patches were flattened. Patch embedding is performed and it is passed through the transformer encoder. Then it is passed through MLP head, and finally the classification is performed. So coming to the results, so here we have taken 600 images. From that, 480 images were used for training and 120 images for testing. So since the deep learning model requires a large data set, we have increased the data set by using data augmentation techniques of flipping and rotation, and we have increased the 480 images to 960, and 80-20% split was performed to split the images. That is, for training, we have used 768 images. And in validation, we have used 198 images and 192 images. And for testing, we have used 120 images. So table 1 represents the hyperparameters of the VIT model. So in this model, for our own data set, we have chose learning rate of 0.001, weight decay of 0.0001, and batch size of 256, transformer layers 8, and epochs of 100. Here, optimizer, we have used Adam W, and the loss we have used is binary cross entropy. So table 2 represents the VIT performance indicators of the VIT framework. In the table 2, we have used percentage split method. With the percentage split method, we gained an accuracy of 90%, precision of 0.91, F1 score of 0.90, recall of 0.90, and AUC of 0.98. Also, we have performed K-fold cross-validation. So we have taken 5 folds in this, and we have obtained an average accuracy of 87.01%. So in this study, we have got better accuracy in percentage split method. So figure 6 represents the ROC of VIT model for the classification of RA. So coming to the conclusion, so here we have employed a emerging technique, that is VIT transformer, to identify RA from health groups in hand thermograms. So we achieved an accuracy of 90% and precision of 0.91%. Thus, VIT model can be used as an assist tool for physicians to automatically detect RA. Furthermore, our thermal images can be employed as an assisting modality to detect RA. So in this context, we can effectively extract the subtle features from the image, and we can and further we can do the prediction. So we have used self-attention mechanism in VIT that makes a model focus on particular areas of inflammation that are indicative of RA, leading to accurate classification of patients. So these are the references. Thank you.
Thank you very much, Ahalya, for first of all keeping your talk within the time limit, and for your good presentation of your work. While we wait for any question, please type in your questions, friends who are listening. So typically VIT models require, general transformer models themselves require a lot of data. Do you think, the data that you have is sufficient because your results were cross-validation based and not really prospective or retrospective study earlier? Any thoughts on that?
Yeah, ma'am. In future, we are trying to extend our data set using generative AI methods. So it will help in more to get the accuracy more.
Right. Did you work with any, so what was your ground truth? Did you work with any clinician?
Yes, ma'am. We have worked with a rheumatologist only. So
What was the
according
ground
to,
truth based on?
I didn't get you, ma'am.
What was the ground truth based on? What is the sort of the offline test to say
Actually, I have done with radiographs also. The same patient's radiographs was also taken. So with that, I have that. So we can say that that's as a ground truth.
Okay, I see. So radiographs with one person viewing it or three doctors viewing it, because ground truth of labeling is also very, very important. That is
Yeah,
the truth.
two doctors, a
One, two.
radiologist and the rheumatologist.
I see. Okay. There's one question from Bharat Govindraju. What was the resolution of images used for this? Is the question he has asked.
It's 320 cross 240.
Yeah, FLIR is what you
Yeah,
mentioned.
yes.
Yeah. Okay. So, but still, and also you kind of, took patches of it, right? So that's what you
Yes,
mentioned.
ma'am.
Yeah. Okay. Thank you very much, Ahalya, for your very good, well presented,
Yeah, thank you, ma'am. Thank you
Yeah.
for this opportunity, ma'am. Thank
Thank
you.
you. Thank you. And one last question. What do you want to do, beyond this? Like, what's the future work like in this?
Future workers, I'm trying to extend the data set, and I'll be working with other kind of transformers, and in quantum computing also I'm trying to work.
Yeah. So my small piece of advice based on what it takes to make this a real thing is to work on retrospective and prospective data. That means you make sure that you're not doing cross-validated accuracy and publishing only that. So you should really make the training set and the test set very, very unique. I know this is different in a cross-validation setting, but it's not sufficient. You need to have an unseen data and then try to predict on it. And that's when you know what's the real accuracy, right? My suggestion would be that to
Yeah,
do
okay, sure, ma'am. I will try
at
on
least
that.
a retrospective analysis would be
Yeah,
good.
yes, ma'am.
Yeah.
Yes, ma'am.
Then the claimed, accuracy would be the right thing. Thank you
Yeah,
very
yes,
much once
yes,
again.
ma'am. Okay,
Thank
thank
you.
you, ma'am.
Thank you so much, Sneha and Ahalya on that. So the next presenter is Ronak Dedhiya. He happens to be from Niramai as well. Ronak, please, you can come in, and Ahalya, please stop sharing your slides. And Ronak is going to talk about thermal radiomics for early detection of diabetic foot ulcers, obviously using AI and infrared thermography. Over to you, Ronak. It is 4:33. You have time till 4:43. And then we're not seeing much questions from the audience. Please drop in your questions throughout don't have to wait till the end. Just whatever thoughts come during the presentation, please do drop in the question. Over to you, Ronak.
Yeah, hi. Hi, everyone. I'm Ronak Dedhiya from Niramai Health Analytics. I'm going to present our work on thermal radiomics for early detection of diabetic foot ulcer using infrared thermography. Contributors Rajas Prasad from Ramaya Institute and under the guidance of the mentors, Dr. Shiva Teja and Dr. Geetha Manjunath. So to start with, the problem we are trying to solve is the diabetic foot ulcers. Around 422 million people worldwide are affected by the diabetes, and the people which are affected by diabetes, out of 15% of those individuals have the foot complication, which is called as diabetic foot ulcers. Among this 15% of individual, we have 85% of the people who have to go through the amputations. So early detection of the diabetic foot ulcer actually can prevent the severe complication. As per the census for the India, around 101 million people are affected with the diabetes, and 1 out of 4 per individual can have the diabetic foot ulcer as an issue. So what could be the technology which could be used to have an early detection for DFU? So one is a thermal imaging, wherein the infrared thermography is able to identify the abnormal heat distribution in the affected foot. Usually the diabetic foot ulcer, people have the nerve damage or poor circulation and inflammation. So as you can see from the images on the right side, the thermal cameras are very well able to capture the thermal variations as small as 50 millikelvin and help us to distinguish between these food which are affected with the complications and which are not. When we are going with a manual interpretation, it has been seen that it's being subjective, and it takes a specialized expertise in order to do an accurate interpretation, because for even food complications, there are various levels for the levels within the diabetic foot complications. So what is the proposed solution is to have an end-to-end automated and explainable system using thermal radiomics to detect the DFU from thermal images. wherein we have the input IR images, and we first of all segment the foot regions. Usually the image can come up with the various background. Maybe if a strict protocol is followed, then it's not a problem. But in the real world scenario, we may have to segment the foot regions, the pixels related to the foot, and then we extract the necessary features, which are nothing but the thermal radiomics features, which can help us to distinguish whether the foot is being normal or has a foot ulcer complications. So coming to the first part, which is the foot segmentation, as you can see, the images can come from the standard strict protocol, wherein the background is clear. Otherwise, there could be images wherein we have the head of the person or the other body parts which are visible into the images. So here, the traditional methods, for example, thresholding or snake method or genetic algorithm, may struggle to work in the real scenario. So we want a method where the pixels which are related to the foot regions can be segmented very well. And for that, we propose a unit mobile net V2 architecture, which is a lightweight encoder decoder architecture. Now, and it captures a high level semantics in order to detect the region of interest. It's lightweight because it uses convolution, 1D convolution network. And because of this, it helps for the easy deployment as well. For training this particular model, we have used a combination of dice and entropy laws. And we have extensively used the data augmentation, such as blurring, scaling, flipping, in order to train the network. The next stage is the DFU classification with the thermal radiomics. So for the segmented foot region, once we obtain the region, we extract the thermal radiomics given in the paper. This radiomics relates to the temperature features. We here wherein we identify the abnormal region or the hotspot regions, which are very critical in identifying the foot ulcers. Also, once we identify this abnormal region, we try to characterize the area region uh, with the shape and the size characteristics of the abnormal region. And last feature is the symmetry feature, wherein we compare the thermal variations with the contralateral foot and try to get the symmetrical features. So combination of this, all these features are used in order to classify whether the patient has a diabetic foot ulcer complications or not. In order to evaluate this discriminative features, we have trained on the three models, which are XGBoost, Random Forest, and SVM. XGBoost is an ensemble for the gradient boosting framework, and Random Forest is an ensemble of the decision trees, and SVM where we have the support vector in order to identify the optimal boundaries to classify the two classes. So for our training, we have used two open source dataset. One is a Planter dataset, which is released in 2019. We have 167 participants here, where 122 images are diabetic, having a foot complication, non-diabetic has 45 patient. Similarly, we have found another dataset, which is stand-up dataset. It is released recently, 2023. We had 184 participants, out of which 145 were diabetic with foot complication, 39 were non-diabetic. In this, we had also additional images which were captured after the cold stress was applied, and this was used for the segmentation model, not for the diabetic versus non-diabetic complications. The reason is the planter and stand-up, we capture the images without any cold stress. Only we wanted to see the thermal variations after the cooling. So experiments and results. For the segmentation, we had total of 582 images overall, combining the stand-up dataset, planter dataset, and additional images for training and testing the segmentation model. We have employed 5-fold cross-validation in order to evaluate the model performance. And these are the parameters which have been used. Since the dataset is smaller, we have used data augmentation, blurring, flipping, scaling, etc. And we have compared it with the state-of-the-art result unit, which was having a dice score of 0.957. We see an improvement with the unit MobileNet V2 architecture. Major improvement we have also seen in the model size parameter, where we have significantly reduced the size of the model from 90 MB to 5.5 MB. This gives us the pixels which are related to the foot region. Once we obtain the this segmented region, we identify the features which are the thermal radiomics features for our combined data set. So for the classification task, we have we have trained the machine learning model on a combined data set of from the plantar and the stand-up data set, which we have around 351 images. This include 267 diabetic and 84 non-diabetic participant, which is a combination of plantar and stand-up. We have used a 5-fold cross validation in order to ensure the reliable performance evaluation. And hyperparameter tuning has been done for each of these model type, random forest, XGBoost, and SVM. For random forest XGBoost, we have tuned the N estimators and max depth and kernel for the SVM model. So this is the results we have got that with proposed thermal radiomics with XGBoost. Here we have not only compared our result for the combined data set, but for individual data set also as an exploratory analysis. What we have found out that among the proposed thermal radiomics with XGBoost for random forest SPM, XGBoost has given us overall good results, better results than rest of them. Also, when we have compared the state-of-the-art results which were available, we have seen a significant improvement in the results on each of this data set, especially for the F1 scores and accuracy. So on the conclusion, we have seen a very high AUC. Like for each of this method, we see AUC more than 90%. With the proposed method, which shows the potential of non-invasive thermal imaging combined with the AI for early DFU screening, such that we can have an automated DFU screening with this proposed method. We also see that this thermal radiomics are very highly effective features, able to give very high AUC when compared to the recent techniques. And use of this thermal radiomics also make it easier for clinician to interpret the results. Foot segmentation, we have obtained, with which are having the images with different imaging condition and high DAX index of 0.97. So future work will involve like clinical validation on larger data set with the diverse populations. And as ma'am suggested, with a retrospective study on this data set. Yeah, thank you.
Thank you very much, Ronak, and thanks again for staying within the 10 minutes allotted. Really appreciate that from both the speakers. And also it's nice to see, a lot of dialogue from the about the previous talk as well on the chat. So great platform to interact. Ronak, you already have 2 questions for you. First question from Ahalya, your prior speaker. How was the mask generated for the unit segmentation? So the good part of what Rona presented is both the segmentation angle, where people don't have to cover the rest of the body. So that's wonderful. And also the fact that he has compared the classification with different techniques, right? So the results with different techniques. Oh, yeah, Ronak. Ahalya wants to know how the mask was generated.
Yeah, right. So we didn't have a ground truth for the masking. So we had around like 582 images. So we have used first a segment anything model, which automatically segments the region of interest. So we have segmented with the help of the segment anything model, we segmented the region of interest, which is the foot region. And then we had like 5 to 6 people who could verify the crop points or the mask region, and they have verified those images, and if there were any correction which are needed for those images, those correction were done, and then the final data set was created as a ground truth in order to train end-to-end 5-fold segmentation model.
All right. Hope that was convincing. Yeah. So there's another question from Bharat Govindraju. How were the features extracted after segmentation to feed into SVMRF? You talked about thermal radiomics. He wants to know how you extracted the radiomic features.
Yeah, so the details exactly about the techniques are mentioned in this paper. But to give a brief overview, once the segmented region is identified, we have both the foot, and then we identify the abnormal region or the hotspot region, which is a kind of an advanced thresholding based technique where we identify the region where using both the foot histogram, we identify a region of interest which is abnormal. And once we identify that abnormal region, we calculate various features like IP cell, how much the temperature increases there with respect to surrounding region, shape and size attributes or characteristics related to that. And we also compare both the foot, contralateral foot, how much the difference is there, how much the symmetry patterns are there. So all those features are extracted. Total 10 thermal radiomics features are extracted, and then we train the classifier network.
Yeah, just to add, this thermal radiomics, several of these were used in breast. And so it's very interesting that you develop a set of features for one application and somewhat similar radiomic features, which are more domain dependent, are applicable to other problems, which also shows that thermal imaging has amazing applications across different body parts, So I think if all of us, whenever you're extracting features from a thermal image, if we call it thermal radiomics, we'll start creating that terminology, right, around the world, starting with this platform. Thank you, Ronak, for that. And any last questions? Somebody wants to unmute and ask, please do. Yeah, one observation, I know I could have mentioned it before, but so Ronak, when you describe the data set, right, I clearly noticed now that there is a bias in the other side, right? The number of people with diabetic foot was much higher than the number of people without, which is obviously contrary to how it is. So we will have to sort of look at more realistic data, but it's, of course, while training, we want to capture all possible abnormalities. So this is okay. And I know just like we did cross-validation in Ahalya's paper, here you're doing it. So this is the way we get started. But yeah, for real use, we need to do retrospective analysis on similar kind of a distribution of patient data. So if you have any comments, you can mention, or I'll go to the next question there. From Manas, it says, why 10 radiomic features chosen? Why are these 10 features chosen?
Yeah, so we have actually experimented with other features as well, right? Like GLCM based features were there. We also tried out neural network based features. What we found out that when we use this features, which have been proven, effectively for the breast cancer, we have also found that it has been, across the data set also, like plantar data set, stand up, and even the combination. This has worked, I mean, much better than compared to rest of the features which we tried out. One was this reason to go forward with it. Yeah.
Yeah. So, and also what happens in us is that, so for old timers, people who've been in this MLAI research for more than a decade, we will remember, or even more, right? We'll remember that only data-based classification or domain-based classification, right? So the deep learning versus explainable aspects of it, taking domain information about the disease domain, I'm saying, there's always this conflict of should we make it more data-based modeling or domain-based modeling. So by having these radiomics, which are more domain-centric, we try to imbibe the semantics of the medical reason behind it into the feature set. And so we found this very, very, starkingly in the breast cancer domain, and the same thing seemed to be work. So something that you learn in the medical field, try to impact, model it in the data that is the machine learning feature wise, and then it actually works very, very well. Okay, thank you so much, Ronak. This is great. Okay, I wanted to close it, but there is one last question from Shrikar M. Any comparisons with using different segmentation models like MED, SAM, mask former, family, etc., and any thoughts on how this may affect performance based on quality of segmasks generated? This will be the last question, Ronak, please.
Yeah, so we have actually only compared with a unit model. One is a simple unit, and then we tried unit MobileNet V2. We haven't, so with the SAM model, we have to actually provide some prior input. So we cannot, directly use that particular model in order to get the segmentation. However, there are other models which we could also try. Probably we may get some performance boost. But this has given us good enough results. And when we saw it, there were, I guess, it was good results as compared to yeah. Sam.
Okay, we are really running out of time. Thank you so much for the questions. Keep asking the questions on the chat, and Ronak, please answer for the next 10 minutes. Okay, so we move on to the next speaker, Mehdi Etahad Tawakal, sorry if I pronounced it wrong, from Shahid Beheshti University of Medical Sciences, Iran. And Mehdi, are you there? Yes. Thank you, Mehdi. He's going to talk about evaluating radiomics features. Evaluating radiomics feature reduction for thyroid nodule segmentation. So yeah, we can see your slides. Out you go. Thank you so much. Please.
Okay,
Maybe.
share it. Okay, yes. Greetings, everyone. I would like to talk about our study title, Evaluating Radiomics Feature Reduction for Thyroid Nodule Segmentation in Thermal Imaging. Okay, to better understand the concept of this study, we start with thyroid nodule. Thyroid nodule in thermal images refers to an abnormal growth in the thyroid gland visualized using thermal imaging, a technique that captures infrared radiation emitted by the body's surface and converts it into temperature data. This imaging method detects temperature variations that may indicate the presence of a nodule due to changes in local blood flow and metabolic activity. Radiomics involves the extraction of quantitative features from medical images for detailed analysis and interpretation, a process that typically encompasses several pre-processing stages. These features capture a range of image attributes, including intensity, texture, shape, and spatial relationships among pixels or voxels. In this study, we extend our investigation by applying 4 feature selection models, including PCA, LDA, TSNE, and RFE, to reduce the dimensionality of radiomics features for comparison. PCA and TSNE are unsupervised methods, while LDA and RFE are supervised methods. Our goal is to further validate the efficacy of feature reduction techniques in improving the analysis and evaluation of thyroid thermographic images. Okay, in this slide, you can see the flowchart of the overall methodology. In the first part, for data collection, data were gathered from outpatient endocrinology and surgery clinics at Antonio Pedro University Hospital and the Federal University of Fluminense in Brazil. For each of the 46 patients of this data set, 20 images were captured every 15 seconds over a 5-minute span. An endocrinologist annotated the regions of interest in these imaging. In the next part, for pre-processing, the original images were loaded from dataset, converted to grayscale, and normalized for consistent processing. After this part, the grayscale images were divided into non-overlapping 5x5 sub-images, and so radiomics features were extracted from all of these sub-images. After that, for the feature reduction, the 107 extracted features were reduced to a single component using feature reduction models. As previously mentioned, the reduced features were reshaped into new feature map, which served as input for our models. Following feature selection, we employ 3 deep learning models. UNIT with the VGG16 backbone, with ResNet 50 backbone, and with DenseNet 121 backbone to perform accurate segmentation of thyroid nodules. To evaluate our model, we assess factors such as accuracy, loss, the Dice coefficient, sensitivity, and specificity. However, the most important indicator between these was Dice coefficient due to segmentation task. Okay. In this slide and the following slides, we present 2 examples of model prediction in image segmentation. For each case, 4 feature maps obtained from the feature reduction method. The predicted areas and the actual mask areas are shown separately on each slide. In this slide, we see the original image, the feature map obtained from PCA, and the image containing the predicted and the actual regions arranged from left to right. As can be observed, the predicted area has minimal overlap with the highlighted yellow area, which is the actual mask region, indicating So in this slide, using the feature map obtained from TSNE, we observed that the model predicts a wider area compared to the PCA method. Although it includes the actual region, the dice coefficient is still 55%. And for RFE, in this slide, we also see the model's prediction using the input feature map derived from RFE, which predicts a more specific area compared to the previous method. However, the dice coefficient is still below 60%. And at the final feature selection model with LDA, in this slide, we see the best result using the input feature map derived from LDA. The model has almost successfully predicted the target area with both high specificity and high sensitivity, achieving a dice coefficient of 73%. Notably, the feature map obtained does not show any particular pattern in the target area to the human eye, but the model has identified a meaningful pattern to predict, well, in this, in the right picture, we can see with maximum overlapping the highlighted area and the prediction of the model. So for case 2, in the following, we evaluated the example case. As can be seen, the actual area is larger compared to the previous example. However, the model's prediction using the input feature map derived from PCA did not have high sensitivity or high specificity. So for RFE, the model's prediction using this feature map appears disorganized, suggesting that the model has learned in a non-specific learning from these inputs. And with the TSNE method, similar to the RFE, we still observe disorganized in the predictions. In this method, there is only 12% agreement based on the dice coefficient. And again, in this case, using the LDA method, we see a prediction that is close to the actual mask. In the corresponding feature map, we can also observe the actual area highlighted. The model achieved a high dice coefficient of 82% in this example. So to see better result, to see the result in better way, for better comparison, in this table we can see the indicators which were mentioned to evaluate our model performance. As we found out from the methodology slide, for LDA, due to better performance with VGG60 backbone, we use two another models. So if we see the LDA dice coefficients, we will observe that the performance is better in comparison with other feature selection methods. So unit with a VGG60 backbone using LDA achieved the highest dice coefficient among all feature reduction models. 40% compared to our previous study, which reported a highest dice coefficient of 28%. This represents a noticeable improvement. The average specificity in LDA and PCA surpasses the other models, with both exceeding 98%, while the others remain below this value. Although there hasn't been a substantial increase in sensitivity, the high level of specificity particularly noteworthy. In diagnostic tests, achieving high specificity is crucial, and given that LDA serves as a diagnostic model, the result is especially significant. So, the mask being square-shaped and relatively small compared to the background may have artificially boosted the accuracy. Moreover, the limited and non-diverse sample size, despite the use of shuffling, likely impacted the results. The novel aspect of this study lies in the integration of feature reduction with deep learning for segmenting thyroid nodules, especially with a limited data set. Our model has shown improved segmentation accuracy over several iterations. However, due to the constraints of a small data set, our conclusions should be considered preliminary. Okay, in the last slide, we can see the future works. In future research, having access to larger data sets will significantly improve their learning process, especially when the data is well distributed and covers a diverse range of cases. Specialized data sets labeled for specific conditions such as benign or malignant tumors would be particularly valuable, allowing the model to capture the distinct patterns associated with each condition. Thank you for your attention.
Thank you very much, Mehdi. Because you actually used up 12 minutes. We have one question for one, time for one question. If anyone has, if I can't see anything on the chat. So my question to you, in the results slide, right? You mentioned VGG 16, I think, used for all of the segmentation. First of all, it's very good work. You've done the detailed segmentation, feature reduction techniques and analysis, but not sure if you go to the slide number 12 results, we see most of the results are good for VGG 16 with only less than 1% difference for different segmentation. So like if you look at average accuracy or even it's up to 1% change in the specificity. And also LDA assumes some kind of a Gaussian distribution. So is there something in the data set that you used which is making one of the feature reduction technique better than the other? Like what was the sample size for evaluating the specificity, for example?
Okay, can you repeat your question?
So I actually did multiple observations. One is the difference is less than 1% across the different segmentation technique.
Yes.
And maybe just to keep it short, what was the data set, the size you used to compute the specificity?
Yes, the specificity is high because, as we see in the formula of the specificity, that true negative pixels is high in this feature map. So the changing in this number, for example, 98% to 99% is so the range of the changing is so low because of this. The key point, yes.
Okay, so maybe we'll take this offline.
Sensitivity is, we can see that sensitivity changes in the wider range. Yes.
Yeah. Okay, I think you should continue the good work. Sensitivity is also around 50%, which is coin toss. So
Thank you, Mom,
but
this
it should be better than the coin toss, which is 50%. So, okay, over to the next speaker. Thank you so much, Mehdi, for this good work. And please continue to make sure the sensitivity is much, much better. Maybe balancing the specificity also helps. Thank you so much. Really appreciate your good work and your interest to present in this. So we move on to the next talk. And if anyone has any question to Mehdi, please post it on the chat. Meanwhile, so I invite Vasilios Alivizos from KTH, Royal Institute of Technology, wonderful institution. I've been there in Sweden. Thank you for coming in, Vasilios. You're going to talk about reverse circular logarithmic LBP for diabetic foot ulcer detection. So please share your slides and please keep your talk to 10 minutes or less because we are really running out.
I prepared the video, so let me know if you can hear the video. I will start playing now.
It's just coming in.
Yep. Hi everyone.
Yes, we can
My
see
name
it.
is Vasilios Alivizos, and I'm from Karolinska Institute from Sweden. And today we'll present the reverse circular logarithmic LBP for diabetic foot ulcers detection. Start off with the motivation of this project. Diabetic foot compilations are significant concerns for patients with diabetic mellitus, affecting more than 60 million individuals worldwide over a lifetime, up to 34% of diabetic patients may develop diabetic ulcers or DFUs. And key risk factors include peripheral neuropathy, peripheral arterial disease, and foot deformities. These conditions can lead to serious consequences like infections, osteomyelitis, or even amputation if undefined or unmanaged promptly. Early detection of these complications is very important to prevent severe outcomes. Infrared thermography has emerged as a valuable non-invasive diagnostic tool, which allows for evaluation of temperature difference in the plantar area, which can indicate underlying pathological changes. Increased plantar temperature, for example, is associated with higher ulceration risk. And in this context, we aim to enhance the automated detection of these temperature variations using advanced texture descriptions and machine learning models. Local binary patterns, known as LBPs, are simple yet powerful texture descriptors used in image processing and computer vision. They work by comparing its pixel by its neighbor's pixels and coding this relationship to a binary number. LBPs are computationally efficient due to their low complexity and fast computation, making them suitable for real-time applications. They enhance textual classification by capturing micropatterns within the image, and one of the key advantages of LBP is their rotation invariance. They are robust to change to image orientation, which is important when analyzing textures that may appear in different orientations. Also, LBPs are efficient for developing homogeneous textures, making them especially suitable for analyzing thermal images where the temperatures disrupts may indicate underlying condition. And I'm sorry. And building up upon above this traditional LBP, we propose the reverse circular logarithmic LBP or RCL LBP. And the main motivation behind the RCL LBP was to enhance the textual classification by introducing a different calculation approach. First, the RCL LBP starts by calculating in reverse direction with the logarithmic distribution. This approach allows more comprehensive capture of textual variations, and we employ circular neighborhood sampling to achieve rotation invariance. And by sampling these pixels in circular patterns around the circular pixel, the RCL LBP works with textures that appear identical by rotated in a rotation to these LBP values. Moreover, we address intensive scaling by incorporating logarithmic normalization with logarithmic number systems, and this normalization manages variations in lighting and intensity scaling, making the description robust to change in the illumination. And for the evaluation of our experiments, we saw that we compared with 9 different LBP variations, including the original LBP variation and several others. We use thermographic images from diabetic and healthy patients, applying each LBP variation to exact texture features. These features were used with an XGBoost classifier to the final classification. We measure performance using metrics, including accuracy, sensitivity, and specificity. The results show that RCL LBP achieves accuracy of roughly 77% in combination with LBP scenario, and roughly 80% in the anikosome combined scenario. Its sensitivity was high as 92%, indicating that this effectively identified positive cases. However, the specificity was moderate, suggesting that there was some trade-off between sensitivity and specificity. And by analyzing the tenfold cross-validation results, we obtained that some certain trends, and RCL LBP demonstrated a high sensitivity, meaning that it was more effective as correctly identifying patients with diabetic foot compilations. However, its specificity was quite lower compared to some other LBP variations. This shown us that LBP is still a good detector for true positives. However, sometimes we had some small percentage of false positives, and the high sensitivities can be attributed to the combination of circular neighborhood sampling and logarithmic normalization, which enhances the detection of substitute texture variation associated with diabetic foot ulcers. The lower specificity suggests that further refinement may be needed to reduce false positiveness in the future. Another important aspect of our study was analysis of the memory consumption. RCL-LBP was an average memory consumption of 60 megabytes, which is slightly lower than compared to convolutional neural networks, including VGG16, which is it's close to roughly a gigabyte of RAM, depending on the pipeline. The low memory consumption of RCL-LBP makes it a little bit better suitable for applications that computational resources are limited, including low computation devices. In comparison to convolutional neural networks, RCL-LBPs offer a faster computational with lower memory requirements, but still providing some good accuracy for specific tasks. Now, to wrap up some take-home messages, we introduced RCL-LBP as an extension of the traditional LBP, and RCL-LBP enhances texture classification through rotational variance and logarithmic normalization, and our results show that RCL-LBP has high sensitivity in detection diabetic foot ulcers using inferred thermography, and is computationally efficient, require less memory, offering a faster processing compared to some other more complex models like convolutional neural network. However, there is a trade-off in specificity indicated they still need some refinement of the architecture of this model. While this model shows lower specificity, the high sensitivity is still beneficial for the detection and for any task. And for future work, we plan to explore applications with less computationally intensive applications, leveraging the low computational requirements. And we also intended to investigate partition intervals and how they can improve the description of the performance. So thank you so much for listening to me. I'm now open take some questions.
Yeah, thank you. Thank you very much, Vasilius. That was an excellent work where you had a very thorough analysis of sensitivity, specificity across different models, as well as the size parameters. There is a question from Ronak. How clinicians could interpret the RCL-LBP output, or how could it be used to guide clinical decision making? So did you work with doctors, and if so, how did they use your tool? Was it explainable?
No, we mostly work with a predefined clinical predefined data set, and the work it was mostly focused on the development of a lightweight model that could be work easily with low computational either IoTs or low computational systems, and the other motivation was to be as good with the low resources as possible.
Okay, thank you. There's another question. This will be the last question from the figure. How were the different local binary patterns computed? You showed multiple binary patterns. He's asking how were they computed. So the next speaker, please go through.
Roughly, the average was quite similar to RCL, LBP. However, in terms of now of the total number of computations, they were a little bit different because we were just limited for the logarithmic normalization. But in terms of performance or the general output, they're quite similar with different LBPs. And one other significant, important take-home message is that we have also to consider that we are using 10% almost with state-of-the-art models in comparison to others. So we have to also consider this, and we have a difference of 20 to or even sometimes less, 15 to 20% less accuracy, state of the art.
Okay.
But still, it's quite
Okay.
impressive.
Okay, interesting. So there is another question. Please answer that on the chat. Thank you again, Vasilius, for your time and wonderful presentation and work. Please continue the good work and get clinician feedback is one thing I would say. And good that you have edge-based future, which will make every mobile DFU device. Thank you. All the best for your future. So we have the last presentation in session 1 coming from Saida Besnili from Turkey. Saida, please start sharing your screen. Saida is going to talk about the effects of balance and strength on thermal heat map. She is from AI Vision Tech, Turkey. Over to you, Saida. You have 10 minutes. We have actually eaten into your break time, so hopefully we'll have a shorter break. Over to you, Saida.
I share my screen.
It's coming up a minute. Yeah. No. Can you share again? It tried to come, but it broke. Can you share again? Where do we have her slides?
Sorry. Okay.
It's not. Maybe you can share just your PPT rather than the full screen. You can see that you started sharing screen sharing, but it's not showing anything. So instead of screen sharing, can you share the PPT itself, just the application, PPT or PDF, whatever you're sharing? Yes, now it's coming. Yeah, over to you. Please go ahead. Put it in screen slideshow mode and please continue.
Hello everyone, I'm Şeyda Besnili. I work as an artificial intelligence engineer at AI Vision Tech.
We lost your presentation. Sorry, Saida. Can you share the presentation again? Maybe you can just present without the slideshow. Looks like there is an issue.
Can you see?
Now it's coming, yeah. Maybe when you put it in slideshow, it's going away. You can present in this mode itself. Please go ahead.
The study I will present to you examine the effects of balance and power on the thermal heat map. The participants' thermal temperature values, isokinetic values, and balance values were taken as specific measurement procedure, and the relationship between them was statistically analyzed. Participants, the data used in the study were obtained from 11 basketball athletes. The data were thermal temperature values, isokinetic test values, and balance test values obtained before and after training. In our study, we used the FLIR T540 ESD thermal camera to capture precise thermal temperature data. This high-resolution thermal imaging device allowed us to record temperature change in our athletes' muscles. To ensure accuracy, athletes were given 25 to 30 minutes after training to cool down to their baseline body temperature. This time minimized the impact of heat build-up immediately after exercise, allowing us to obtain more consistent and reliable temperature measurements. During this time, athletes remained standing to prevent any temperature change that might occur if they were sitting or leaning on the surfaces. This controlled environment was crucial to obtaining consistent data. Images were captured from a distance of 2 meters, focusing on the lower extremities from both the front and back angles in room with a constant ambient temperature. This setup allowed from standardized, repeatable conditions across all participants, ensuring that the images collected reflected the natural heat patterns of their muscles without being affected by environmental conditions. All thermal assessments were performed using AI for Sports from AI Vision Tech, an advanced AI-powered thermal imaging system. This software allows us to automatically identify and assess muscle areas, detecting signs of fatigue or potential injury. The AI for Sports system uses machine learning algorithms to accurately process these thermal images, providing early indicators of muscles issues that are important for injury prevention and overall athlete health. For the isokinetic strength test, basketball players warmed up with 5 minutes of exercise and 15 minutes of cycling 30% resistance. They were fixed to the test chair and completed 5 maximal knee extensions and flexions 19 degrees sec and 180 degrees sec, repeated in 3 sets of 5. Isokinetic test values indicating peak and average muscle strength for both legs were recorded. For the dynamic balance test, the participants' balance was measured on the Biodex balance system while standing on the leg with eyes open, level 5 difficulty, and arms crossed. 3 balance scores, general balance index, anterior-posterior index, and medial-lateral index were recorded. Pearson and Spearman correlation tests were performed to examine the relationship between thermal temperature values and isokinetic test results, the relationship between the results and balance test results. In all evaluations, p-value values less than 0.05 and greater than minus 0.05 were considered statistically significant. R-value values greater than 0.5 and less than minus 0.5 were considered statistically significant. In the correlation analysis between isokinetic strength testing and thermography, a significant correlation was found in the flexor group. The relationship between the isometric strength of the hamstring group muscles and the thermal heat map is important in terms of showing that the hamstring muscle group should be prioritized in the analysis of thermal evaluations of basketball athletes. In our study, the relationship between the mean temperature value of the vastus lateralis muscles and the overall stability index, anterior-posterior index, and medial-lateral index of the balance test results, as well as the relationship between the mean temperature value on the ankle region and overall stability index, anterior-posterior index of the balance test results, were observed to be significant according to Spearman and Pearson correlation test. In addition to evaluation of ankle injury risk of basketball athletes, the thermal finding we observed in the vastus lateralis muscles and ankle region in terms of balance parameters, the frequency of knee injuries are adaptively loaded by vastus lateralis muscles, and especially knee injuries occur as a result of this adaptation. Considering that the most common injury types in Turkey are ankle, hamstring, and knee regions of athletes, thermal assessment is a tool that can be used as an injury risk analysis assessment. Thank you for listening. For your question, can you contact me via email address?
Thank you very much, Saida, for this good work where you're looking at a very, very useful application of keeping athletics and football players healthy. Any question from the audience, if anyone wants to unmute and ask? So I know it's the break time, so everyone is looking to have a break. Saida, one comment, as you probably know, Thermohuman works on different applications for sportsmen. Really suggest that you work with, I think, Ismail, so that you can benefit, both of you can benefit. It's a really, collaborative, this is a platform where we want to create collaboration, and we can really see that there is a possibility of you collaborating with, with Ismail from Thermohuman, for example. So we will connect you, and please see if there is a way of collaborating. Thank you.